Welcome back, my cardiac casualties. Today's guest of dishonor, acute pericarditis, or as I call it, inflammation of your heart's emotional support hoodie. And like all cheap hoodies, it itches, it squeaks, and it overstays its welcome. Etiology. Who hurt you? Causes. Oh baby, it's always drama. Viral. Coxsackie equals toxic situationship that spreads too easily. TB is the old-school villain, still relevant in low-income settings. Uremia means the kidneys start beefing with the heart. MI aftermath is early fibrinous and late Dresslers, the passive-aggressive autoimmune queen. Radiotherapy happens because cancer treatment said side quest. CTD, like lupus, shows up everywhere uninvited. Malignancy with lung and breast cancers gatecrashes the pericardium. Trauma includes both blunt force and emotional. The mnemonic. Very tragic, unhappy myocardium really can make trouble, representing viral, TB, uremia, MI, radiotherapy, CTD, malignancy, and trauma. Pathophysiology, the drama inside. Trigger, inflammation begins. Cytokines, IL-1, IL-6, TNF-A, crash the party. Vessels leak, fluid floods pericardium. Fibrin lays down, scratchy scarf around the heart. If bacterial, pus, because why not? Chronic fibrosis and adhesions. Heart locked in a Victorian corset. Knock, knock. Who's there? Fibrin. Fibrin who? Fibrin your heart tighter than your ex ever did. Clinical features, signs you're falling apart. Chest pain, sharp, pleuritic. Better sitting forward, the heartbreak yoga pose. Radiation to trapezius, shoulders called in as backup. Pericardial rub, squeaky haunted violin. Low fever, malaise, vague and dramatic. Villain roast. Pain that improves when you lean forward. Even your symptoms have commitment issues. Mnemonic. FRAP fever. Rub. Atypical chest pain. Sharp. Pleuritic. Better forward. Pain radiates to trapezius. Investigations. CSI. Heart edition. The ECG shows in 60% of cases a widespread concave ST elevation, which is the heart's open letter to drama and PR depression, known as pericarditis royalty. Blood tests include CRP, ESR, and FBC, indicating inflammageddon and troponin, which if elevated points to myopericarditis. Echocardiography. Echo reveals effusion in 60%, think heart drowning in its own tears. On a CXR, things look normal unless there's effusion, which I call water weight. For high-def drama, we use CT or MRI, and don't forget pericardiocentesis, but only if it's bacterial, malignant, or a mysterious mess. Management involves cleaning up the mess. Most cases are outpatient divas, but admit if they have fever over 38 degrees, high troponins, or look like death warmed over. First line, NSAIDs and colchicine are the anti-inflammatory power couple. And remember, no exercise until symptoms and CRP settle. Oh, and steroids. Only if you're medically cursed. Complications are the real villain arc. Cardiac tamponade as the heart suffocating in its drama. Pericardial effusion means you can't breathe unless horizontal. Constrictive pericarditis is the pericardium as a concrete corset. And recurrent pericarditis, like a toxic ex, always comes back. Prognosis. questioning whether they will survive. Most do, but advise to admit if there's a fever over 38, subacute onset, large effusion over 20 milliminute, no NSAID response in 1 week, or if they are myopericarditic, traumatized, immunosuppressed, or anticoagulated. And that, my tragically inflamed interns, is acute pericarditis, the squeaky hoodie your heart never asked for. Remember, NSAIDs calm it, colchicine keeps it from coming back, and if tamponade shows up, run. This has been DKA, the villain MD, who diagnoses, dissects, and drags. Subscribe, or ghost me like viral studies. As always, I shall roast 3 comments.